Hi, I'm going to talk about primary biliary cirrhosis, or PBC as it is commonly called. My name is Karen Goodman, and we are going to begin a journey through the disease. So what is PBC? Well, the exact cause is unknown, and there is no known cure. However, it is primarily believed to be an autoimmune disease causing damage and destruction within the bile ducts, leading to fibrosis and cirrhosis. Other theories are that it's genetic, environmental factors such as infectious agents or recurrent UTIs, hormone replacement therapy, cigarettes and the chemicals contained within the smoke, and cosmetics. 90% of your cases diagnosed are women, and the ratio of female versus male is 10-1. So let's look at body systems afflicted: neurological, endocrine, respiratory, cardiovascular, renal or fluid and electrolytes, reproductive, gastrointestinal, musculoskeletal, and last but not least, hematopoietic. Now, these are head to toe. That is how nurses are taught to do an assessment, is head to toe. So that's how we're going to look. So, neurological, hepatic encephalopathy. The exact cause is not truly understood, and it can develop rapidly or slowly. Probable causes, though, can be infection, electrolyte imbalance, anemia, GI bleed, dehydration, vascular occlusion, and drugs. Now, dehydration can be caused from nausea, vomiting, diarrhea, hemorrhage. Vascular occlusion, usually caused by a portal or hepatic vein thrombus or even cancer, and drugs such as benzodiazepines, narcotics, or alcohol. Now, ammonia is a major player in this. The levels of ammonia increase due to the inability of the liver to effectively detoxify the substance. Therefore, it accumulates in the intestine, where it is absorbed and enters into the brain by crossing the blood-brain barrier, causing inflammation and neurological changes. Essentially, it becomes a neurotoxin. Symptoms of this can be altered sleep patterns, irritability, changes in personality or behavior, decreased attention span, impaired mental cognitive function, flapping tremors, muscle rigidity, and coma. Lactulose is your primary treatment. It is an osmotic laxative that causes changes in the pH of the intestine, therefore an acidic environment. It causes excretion of the ammonia through diarrhea. This is usually given orally or through an NG tube at a dose of 20 grams per 30 mils. That's one dose. Or it can be given rectally by enema. And this dose is usually determined by the pharmacist or the physician, much the same as with oral or NG. You give this either orally or rectally every hour until 2 to 3 bowel movements or when the patient's mental status increases or improves. Now, another thing that has been shown to be effective against this is rifaximin. Now, this is a newer antibiotic that is out, and it has less than 1% systemic absorption. Therefore, it decreases the chance of resistance. And its target area is that it works in the small intestine. The dosage is 550 milligrams twice a day orally. It is a very expensive drug. So let's move on to endocrine. Well, arginine vasopressin, aka antidiuretic hormone. This is a major player in regulating water excretion from the kidneys and blood volume. It's synthesized in the hypothalamus and stored in the posterior pituitary gland. Now, in early stages of cirrhosis, peripheral vasodilation and splenic nervous pooling occur, leading to decreased systemic vascular resistance, or SVR. Now, this decrease in SVR triggers the release of AVP and encourages water retention. Respiratory, ascites. Yes, I know people are probably thinking, why the abdomen? But let's go on. Well, ascites is fluid accumulation within the peritoneal cavity that becomes trapped and cannot escape. It's caused by increased pressure in the mesenteric pathways that push fluid out of the vessels and again can't escape. Symptoms can be weight gain, increased abdominal girth, abdominal distension, dyspnea. It causes, here we go, causes breathing problems. The diaphragms shift or move, causing difficulty in breathing. Semi-Fowler's position helps to alleviate this dyspnea, or performing a paracentesis, although not a cure, aids in relieving dyspnea, and it's considered palliative. So cardiovascular. Hypovolemia leads to excessive strain on the heart, causing a cascade of problems. Well, we get decreased perfusion, decreased cardiac output, leading to decreased PP, tachycardia, ischemia, cardiac arrhythmias, or MI, or myocardial infarction, and possibly even death. Moving on to reproductive. Menopause is permanent cessation of menstrual cycles following the loss of ovarian follicular activity. Now, hormone replacement was thought to be a possible environmental factor. What HRT does is assist in providing relief from the symptoms of menopause, which can be decreased vascularization in the vagina or surrounding tissues, reduced genital perfusion or engorgement. But hormones also can cause hepatotoxicity and can cause cholestasis. Moving along to gastrointestinal. Well, scar tissue and impaired bile flow impede the body's ability to break down or digest fatty foods. Therefore, fat is excreted in the stool, or known as steatorrhea, fatty stool. Varices often develop due to the effects of portal hypertension, and we're going to get to portal hypertension here in just a little bit. So, esophageal varices may not have any symptoms until they leak or rupture. You may have rectal varices in the form of internal hemorrhoids. These symptoms might be painful defecation, leading to constipation, and you may see blood within the stool itself, the toilet, or on toilet tissue. Now, thrombocytopenia further complicates the recovery, so may leak or rupture if they occur. Moving to musculoskeletal. Fatigue is the most common symptom of cirrhosis, with up to 75% of your patients having this symptom. Now, this may lead to decreased muscle tone or muscle wasting by lack of physical activity. And women, we know, lots of times put others before themselves and will keep on doing things, or they'll downplay their symptoms. But then it may lead to a cycle of increased fatigue and then not wanting to do things. Muscle depletion may also be caused by malabsorption of protein, vitamin D, and calcium. Now, PBC can cause a decrease in the appetite. Therefore, patients may not have adequate diet intake of these substances and may need a nutritional consult. Hematopoietic. Blood is comprised of three main components: blood, cells, platelets, and plasma. Now, the liver is the largest blood reservoir in the body, holding up to 18 to 25, well, let me back that down a little bit, 13 to 25% of the body's blood supply at any time. Hemostasis problems involves clotting factors, fibrinolytic products, and platelets. Thrombocytopenia is when the platelet count falls below 100,000 platelets per milliliter of blood. Clotting factors, factor 7 is the first to decline, progressing to prothrombin and then to factor X. Now, disseminated intravascular coagulation, or DIC, happens when multiple defects causing clots to form within the general vascular system consume and deplete the necessary components needed for continued clotting. This will lead to uncontrollable hemorrhage and possibly death. Albumin is a main plasma protein and is produced only within the liver. It makes up 80% of intravascular colloid osmotic pressure. Decreased levels can lead to escape of plasma from general vascular system into the surrounding tissues, thereby producing hypovolemia and hypotension. Now, portal hypertension, I said we'd come back to it, and this is where we're going to discuss it. It's a backup of blood flow through liver circulation that results in increased pressure in the esophageal, gastric, portal, and mesenteric veins. The most common cause is obstruction, which is caused by the cirrhosis. Collateral circulation can develop, causing blood to bypass these obstructions. Now, the varices, as mentioned before, can develop in the esophagus, the stomach, and the rectum. You might have splenomegaly, which is an enlargement of the spleen and occurring due to the increased pressure within the splenic vein. Now, also again, ascites, or accumulation of fluid within the peritoneal cavity, occurs due to the pressure forcing fluid out of the vessels and into the peritoneal cavity. So let's look at primary, secondary, and tertiary treatments. So our primary treatment might be a liver transplant. A liver transplant, yes, you're replacing the liver, decreasing the problem, goes away. Now, in some of the articles that I have read, the majority of them say that there shouldn't be any recurrence of the autoimmune disease, and a few say we don't know. Ultrasound and liver biopsy will diagnose this. These are the two main things that help to diagnose and stage your liver disease. Now, uracil-deoxycholic acid is your main primary medication that you want to get people started on. Your secondary treatments would be like your nutritional counseling, your vitamins A and D, and calcium, of course. Cholestyramine for the pruritus. However, that can take up to 4 days to work, and it can cause bloating and constipation. Exercise, physical activity. However, again, it depends on a person's fatigue and what their ability is to do. And we got to consider osteopenia and osteoporosis with that too. Potassium-sparing diuretics for the fluid. Lipid-lowering agents to decrease cholesterol. Lactulose and rifaximin. Okay. Frequent blood tests and doctor visits. We need to follow these and make sure treatments are working. Now, tertiary really is palliative, meaning we're going to treat the symptoms. There isn't much that we can do. Okay, so our modifiable factors that we look at are the diet: low cholesterol, low fat, low sodium, increased protein. Exercise and physical activity, again, take into the fatigue factor. Medication, uracil-deoxycholic acid, cholestyramine, vitamins A and D, calcium, and diuretics. We also need to take into consideration adherence, compliance, and cost. Can we modify the cost? Some of these medications are very expensive, so we may need to get these people on Medicare or into an indigent drug program. Non-modifiable factors: age, race, gender, family history. We can't change any of that, okay? I can't change if somebody's not going to adhere or comply to what the doctor says. We may not be able to modify the cost. We may not be able to get these people onto a program that will allow to help them pay for these medications. What if they're homeless? They're moving around a lot. There's no permanent address. So this is a concept map that takes everything that we've said and puts it together. So let's look at conclusion. No known cure. Okay. Primarily thought to be autoimmune, genetic or environmental factors. Women are the gender that's most affected, 90%. Symptoms are vague and mimic other diseases, making it hard to make a diagnosis of PBC. Sometimes it's found by mistake, just in elevated routine blood tests. Fatigue is the most common symptom. It affects many systems, a domino effect. Think about when you line up those dominoes and you hit the first one, each one continues to fall behind it. Patients need to adhere, it's in capital letters, to diet changes, medications, exercise regime. There are pros and cons to the treatment. Again, some of the side effects of the medications, not wanting to take them, the cost. And then looking at our primary, secondary, tertiary treatments. Okay, modifiable and non-modifiable factors. What can we change? What can we not change with this? And most of all, science continues to advance daily. And somewhere, we hope that a cure may be found for this. That is the end of my presentation. The references are as follows. I thank you for listening and taking the time to